Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Subsidies for Oral Chemotherapy and Use of Immunomodulatory Drugs Among Medicare Beneficiaries with Myeloma by Olszewski et al. My name is Tina Shi, and I am Professor and Chief of the Section of Cancer Economics and Policy at the Department of Health Services Research, University of Texas MD Anderson Cancer Center in Houston, Texas, United States. My oncologic specialty is assessing the economic aspects of cancer care and evaluating the impact of public policies on cancer patients. Chemotherapy is the mainstay of treatment for the majority of cancers. Scientific advances have revolutionized chemotherapy, both in terms of treatment effectiveness and mode of administration. Traditionally, chemotherapy drugs are injectable drugs administered at an oncologist's office. Today, chemotherapy drugs are viable treatment options for many cancers, such as myeloma, leukemia, and renal cell cancer. In fact, prior research have shown a steady increase in the use of oral chemotherapy among patients treated with chemotherapy, from less than 2% in 2001 to close to 15% in 2011. Although oral chemotherapy has successfully transformed several cancers from deadly diseases to chronic conditions, and the oral formulation is convenient for patients, many oral chemotherapy drugs are priced at close to $10,000 per month. People have hypothesized that the out-of-pocket payments associated with these novel drugs could become an access barrier for patients who would benefit from these drugs. This hypothesis was tested in a study by Olszewski et al. That accompanies this podcast. The study analyzed a cohort of myeloma patients extracted from SEER Medicare data. There are two new classes of drugs for patients diagnosed with myeloma, one in injectable formulation and the other is orally administered. Bortezomib is a potassium inhibitor that requires twice-weekly parenteral injections at office settings and is covered under Medicare Part B. Oral immunomodulatory drugs, including thalidomide and lenalidomide, are covered under Medicare Prescription Drug Plan, also known as Medicare Part D. Out-of-pocket payments for the majority of myeloma patients receiving bortezomib should be moderate because approximately 85% of Medicare beneficiaries carry secondary insurance to supplement the 20% coinsurance required by Medicare Part B. The situation is much different and more complex for patients who receive oral chemotherapy because of the insurance benefit design in Medicare Part D. Specifically, the standard Part D plan has 4 phases, and beneficiaries spend their way through these phases in addition to their monthly premiums. First, a deductible phase in the amount of $400 in year 2017. Next, the initial coverage phase, in which beneficiaries pay 25% to 33% coinsurance until they have accumulated $3,700 in total prescription drug costs. Then came the coverage gap phase with 100% coinsurance till patients' out-of-pocket spending has reached $4,550. Lastly, the catastrophic coverage phase, in which patients are subject to 5% coinsurance without the protection of out-of-pocket maximum in many private insurance plans. For expensive drugs like the oral immunomodulatory drugs for myeloma patients, previous research have shown that one prescription would push patients all the way to the catastrophic coverage phase. This high upfront out-of-pocket expense could discourage patients from choosing oral chemotherapy. Low-income subsidies offer financial relief for some party beneficiaries because the subsidy largely eliminates out-of-pocket expenses. Olszewski and co-authors conducted 3 sets of analysis to better understand myeloma patients' treatment choice, the associated outcomes and costs, and whether the subsidy status play a role in such choice. First, they compare the uptake of oral immunomodulatory drugs between myeloma patients enrolled in Part D who receive low-income subsidy at the time of diagnosis and those without the subsidy. Of the 3,038 patients in the study cohort, 1,250 or 41% received oral immunomodulatory drugs. After adjusting for underlying differences in patient characteristics, the study found that recipients of low-income subsidies were more likely to use oral chemotherapy, especially for the subgroup of patients between age 75 and 84. This finding is consistent with prior research that documents a negative association between cost sharing and medication use. Second, the study compared the occurrence of delays in refilling oral chemotherapy prescriptions and duration of therapy by patients' low-income subsidy status among those who received oral chemotherapy. It showed that although the duration of therapy was similar between low-income subsidy recipients and non-recipients, myeloma patients with subsidy were less likely to experience prolonged delay in prescription refill. They also reported substantially lower out-of-pocket expense for patients with low-income subsidy. The median expense for oral chemotherapy during the first year of treatment was over $5,600 for patients without subsidy and only $6 for those with subsidy. This number is alarming because the median annual income for Medicare beneficiaries was less than $25,000, which means for myeloma patients who receive oral immunomodulatory drugs without low-income subsidy, they would spend more than 20% of their income on these drugs alone. Another interesting finding is that low-income subsidy appear to be an effective policy to boost the low treatment adherence commonly found among socioeconomically disadvantaged patients. Lastly, the study compared health outcomes and costs within the first year of diagnosis between 3 groups of patients: bortezomib only, oral chemotherapy only, and a combination of both. It concluded that compared with patients treated with bortezomib, those who receive oral chemotherapy had significantly lower rates of ER visits and hospitalization, but similar survival and costs within the first year of diagnosis. Although fewer ER visits and hospitalization could indicate better quality of life among myeloma patients treated with oral chemotherapy drugs, this conclusion is tentative because patients in these 3 groups may not be directly comparable due to patient heterogeneity across treatment groups. In comparison, the study by Olszewski et al. Confirmed the hypothesis that high out-of-pocket payments could constitute a barrier to access oral chemotherapy drugs for elderly myeloma patients. The study found that subsidies could alleviate patients' financial burden and thereby influence patients' treatment decision. In the case of myeloma, patients have the luxury of having 2 classes of drugs with similar clinical benefits. Therefore, patients without subsidy could opt for bortezomib to avoid a high out-of-pocket payments in Part D. For other cancers, if oral chemotherapy offers superior clinical benefits, the decision to choose an injectable chemotherapy drugs driven by the consideration of high out-of-pocket payments associated with oral chemotherapy could compromise patients' survival. Given that only around 30% of Part D beneficiaries meet the eligibility criteria for low-income subsidy, policymakers must make efforts to find viable solutions within Medicare program to ease the financial burden faced by Part D beneficiaries without low-income subsidy so that novel cancer therapies won't be cost prohibiting for them. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.